So imagine you are renovating a house.
Okay, I'm with you.
You have this grand vision for the main floor, right? Like you want to install a massive, beautiful, heavy kitchen island.
Oh, that sounds nice.
Yeah, but right before the contractors arrive, you discover an absolute structural nightmare.
Uh-oh.
The foundation beneath the floorboards is actively sinking into the basement.
That is bad.
It gets worse. And if that isn't bad enough, the ceiling from the room above is slowly caving in, like literally crushing the space where your kitchen was supposed to go.
Wow.
You are losing the floor and you are losing the ceiling simultaneously.
So you're basically caught in a biomechanical vice, right? You're losing the exact real estate you need to build on from both directions. I mean, that forces a complete halt to any construction plans.
Exactly. And that architectural failure is exactly what happens inside the human jaw after we lose an upper back tooth.
It really is a dual collapse.
It is. Today, the mission for this deep dive into the source material is to explore the microscopic, highly architectural world of how surgeons actually fix this.
Because it's a massive problem.
Right. We are looking at a procedure called maxillary sinus floor augmentation, or, more commonly a sinus lift.
Yeah, a sinus lift.
So we're going to unpack exactly when this procedure becomes a necessity, why our biology demands it, and, well, how dental surgeons manage to pull off this feat of engineering inside the confined space of the human skull.
Because we're basically looking at taking a space that the body has deliberately dismantled and forcing it to rebuild. And we use a combination of fluid dynamics, anatomy, and some pretty advanced biomaterials to do it.
It's fascinating, and we're drawing on a massive stack of clinical literature for this.
Oh, yeah, we have a lot of sources today.
We've got studies from the International Journal of Oral Science, the American Journal of Dentistry, and just extensive reviews on anatomical factors, biomaterials, complication management.
The whole spectrum.
Yeah. And reading through these sources, I think the most striking takeaway is that the human body literally physically reshapes the structure of your face based entirely on empty space.
Right. The body is highly efficient. It absolutely refuses to maintain what it isn't actively using.
Which is wild to think about.
It is. But to understand that efficiency, we really have to look at the underlying physiological trigger. It's a concept called centripetal resorption.
Centripetal resorption. Break that down for me.
So the alveolar bone, which is the specific ridge of your jawbone that houses the roots of your teeth, it's a very unique type of skeleton. We classify it as a tooth-dependent structure.
I was actually reading about this dependency. It means the alveolar bone's only biological purpose for existing is just to hold that tooth.
Exactly.
Like it isn't like the femur or the skull, which have these broader structural rules for the whole body.
Right. Its entire existence is maintained by the mechanical stimulation it receives. And it gets that stimulation from a specialized tissue called the periodontal ligament.
The periodontal ligament.
Yeah. So when you chew, your tooth isn't rigidly fused to the bone, like a screw in wood.
Wait, it isn't?
No, not at all. It is actually suspended in this microscopic hammock, which is the periodontal ligament.
Oh, wow. I always picture them just anchored directly into the bone.
Most people do, but every time you bite down, the tooth depresses slightly into the socket.
Okay.
And that movement stretches the ligament fibers. That mechanical strain sends an active piezoelectric signal right into the surrounding bone matrix.
So it's basically communicating with the bone cells.
It's sending a very clear message to the osteoblasts. Those are the cells that build bone.
Right, the builders.
Yeah. It tells them, hey, heavy lifting is happening here, so you need to keep laying down calcium and phosphorus to keep the area dense.
Which makes sense.
It's a classic expression of Wolff's Law, which states that bone adapts to the loads under which it is placed. But the moment you lose that tooth, whether through, a localized infection or trauma or decay, that vital mechanical signaling just vanishes.
A bone basically loses its workout routine.
Exactly.
And because the body hates wasting energy on idle tissue, it sends in the demolition crew.
Yes, the osteoclasts.
The osteoclasts.
Right. These are large, multinucleated cells, and they secrete acid and enzymes to just break down the mineralized bone tissue.
They just dissolve it.
They do. Without the counterbalance of the bone-building osteoblasts, the osteoclasts just dominate. The alveolar ridge rapidly begins to resort.
So the bone literally melts away.
It melts away, it loses significant vertical height and horizontal width, and it basically shrinks upward toward the roof of your mouth.
That perfectly accounts for the floor sinking into the basement in our house analogy.
It does, yeah.
But the sources highlight a dual collapse. We also have to deal with the ceiling caving in.
Right, the other half of the problem.
The clinical term for this is the pneumatization of the maxillary sinus.
Yes, pneumatization. So the maxillary sinus is the large, air-filled cavity located just behind your cheeks. It sits right superior to the roots of your upper molars and premolars.
Okay, so right above the back teeth.
Exactly. When your teeth are healthy and present, their roots and that dense alveolar bone act as a physical barrier. They basically hold the floor of the sinus cavity up.
I really struggled with the mechanics of this in the reading, to be honest.
It is a bit counterintuitive.
Yeah, because the literature states that when a tooth is lost, the sinus cavity essentially senses the weakness and expands downward, hollowing out the space where the roots used to be.
Great.
And the claim is that the air pressure from normal breathing pushes the sinus floor down.
That's the mechanism, yes.
But wait, so just because a tooth is gone, the air pressure from my own breathing is literally pushing my sinus cavity down to hollow out my jawbone.
It sounds crazy, but yes.
If air pressure is pushing the sinus floor down, why doesn't it also push the top of the sinus up into my eye socket? Like, why does only the floor collapse?
Oh, that is a really fundamental question of craniofacial mechanics. It all comes down to the difference in bone quality.
Bone quality.
Yeah. The roof of the sinus, which forms the floor of your orbital cavity, your eye socket, is made of basal bone. Okay. Basal bone is robust. It's structurally independent and highly, highly resistant to pressure. The floor of the sinus, however, is resting on that tooth-dependent alveolar bone we just talked about.
The stuff that melts away.
Exactly. Once the tooth is gone, the alveolar bone becomes structurally compromised. It's weakened by the osteoclast activity. So when the positive air pressure inside the sinus cavity spikes during respiration, like every time you exhale or sneeze, that pressure naturally seeks the path of least resistance.
And the path of least resistance is the disintegrating bone where the tooth used to be.
You got it. Furthermore, the loss of the tooth actually alters the strain on the periosteum.
The periosteum.
That's the connective tissue lining the bone inside the sinus cavity. This lack of strain triggers increased osteoclastic activity on the internal side of the sinus as well.
So you have cells actively eating away the floor from the inside, while the respiratory air pressure pushes that weakened floor downward.
Right. The air cavity literally hollows out the jaw.
This creates an incredibly severe anatomical crisis for an oral surgeon who's just trying to replace that missing tooth.
A massive crisis.
Because a standard dental implant, the titanium screw that acts as an artificial root, it typically needs about 10 millimeters of solid vertical bone to achieve what they call primary stability.
Yes, 10 millimeters is the standard goal.
It needs enough dense material to mechanically lock into so it doesn't move while the bone heals around it over the next few months.
Right. We measure this available real estate as the residual bone height, or RBH.
That's to a bone height.
Yeah. Due to the combination of the resorption from the bottom and that pneumatization from the top, the RBH frequently drops from a healthy 12 millimeters down to less than 5 millimeters.
Wow, less than half.
Oh, in severe cases of long-term tooth loss, we see an RBH of just 1 or 2 millimeters.
1 millimeter?
Yeah. You are left with basically an egg-cell thin layer of bone separating the oral cavity from the sinus cavity.
If a surgeon were to ignore this anatomy and attempt to drive a 10-millimeter titanium implant into 2 millimeters of bone, the implant would just punch straight through the floor of the sinus.
It absolutely would.
It would be protruding upward into the air cavity, tearing the lining, just waving around in empty space.
And that's a recipe for disaster. The implant wouldn't integrate. It would likely fail completely under the forces of chewing.
Right.
And it could lead to severe sinus infections. Or, in really bad cases, the implant can migrate entirely into the sinus cavity, which requires a massive retrieval surgery.
Nobody wants that.
No. So the timing, the when a sinus lift is required, is entirely dictated by the RBH dropping below that critical threshold of around 5 to 7 millimeters. We have to rebuild the floor and push the ceiling back up.
So to understand the methodology of pushing that ceiling up, we need a deep understanding of the exact room the surgeon is operating in.
Yes, the anatomy is everything here.
The maxillary sinus is an irregular, pyramid-shaped void. The sources say the average adult volume is about 11.3 cubic centimeters.
Right, it's the largest of the paranasal sinuses. But the element that really dictates the success or absolute failure of this surgery is the wallpaper lining that cavity.
The Schneiderian membrane.
The Schneiderian membrane. The entire goal of a sinus lift is for the surgeon to detach this membrane from the bone and stretch it upward to create an artificial pocket.
And then they pack that pocket with bone graft.
Exactly.
Wow.
But this tissue is incredibly unforgiving.
Yeah, I read about this. It is a highly specialized, dynamic biological tissue. The sources say the Schneiderian membrane is composed of ciliated, pseudostratified, columnar epithelium.
Yes, that is a mouthful. Let's break down the cellular makeup of that because it explains perfectly why surgeons are so terrified of damaging it.
Please do.
It is constructed in layers. At the base, you have basal cells resting on a basement membrane. Above them are goblet cells.
Goblet cells, okay.
These are constantly synthesizing and secreting mucin, which mixes with water to form the mucus blanket that basically coats the inside of your sinuses.
Gross, but necessary.
Very necessary. This mucus is sticky. It traps inhaled dust, allergens, and bacteria.
And then there are the columnar cells bearing cilia.
Right. The cilia are these microscopic, hair-like projections that extend directly into the sinus cavity. And they don't just sit there.
They move.
They beat in a highly coordinated rhythmic wave, usually around 10 to 15 beats per second.
Oh, wow.
This continuous sweeping motion moves that contaminated mucus blanket against gravity, pushing it up toward the natural drainage port of the sinus, which is called the ostium.
And that empties into the nasal cavity.
Yes. It is a highly active, self-cleaning escalator.
The physical dimensions of this escalator are really where the surgical challenge lies, though.
Absolutely.
In a healthy state, the sources show the Schneiderian membrane is vanishingly thin. It ranges from 0.1 millimeters to 1.99 millimeters thick.
Extremely thin.
We are talking about tissue that is thinner than a piece of standard printer paper, and a surgeon has to scrape it off the bone and stretch it without it tearing.
It requires an insane amount of delicacy. We have extensive biomechanical data on the stretching limits of this tissue.
What are the limits?
Well, you are trying to create a mucoperiosteal alveolar pocket, basically an artificial void between the bone and the membrane. Studies show the membrane has a biaxial stretch limit.
Meaning it stretches in two directions.
Right. It can stretch roughly 132.6% in one dimension and 124.7% in two dimensions before the cellular junctions literally physically rupture.
So there is a hard mathematical threshold to this elasticity.
Yes, very hard.
The literature indicates that if the local tension placed on that membrane by the surgeon's instruments, or even just the pressure of the bone graft material, exceeds 7.3 newtons per cubic millimeter, it reaches its tensile failure point. It just rips.
Exactly. And because of this extreme fragility, pre-surgical anatomical planning is absolutely critical. Surgeons rely heavily on 3D imaging to classify the sinus into two distinct categories based on how well the membrane is expected to tolerate elevation.
Right. The International Journal of Oral Science paper details this. Type A and Type B sinuses.
Let's start with type A.
Okay. Type A is classified as the stretch favorable type, or SFT. This is obviously the optimal scenario for a surgeon.
It is the dream scenario.
The sinus cavity has a smooth, wide, U-shaped or oval contour. And crucially, there are no bony obstructions on the floor.
Right. The floor is clear.
So the membrane can lift and stretch evenly across a broad surface area, distributing the tension safely.
Precisely. But then you have type B. This is the stretch unfavorable type, or SUT, and this presents massive biomechanical hurdles.
What makes it unfavorable?
These sinuses are often narrow and they taper sharply, forming almost an acute V shape at the floor.
Oh, I see.
The membrane is wedged tightly into that crevice, meaning any upward force concentrates the tension at the very tip of the V.
And that easily exceeds that 7.3 Newton limit.
Instantly, the tissue just tears.
The literature also points out that type B sinuses frequently contain underwood septa.
Yes, septa are a nightmare for surgeons.
These are bony walls or ridges that grow up from the floor of the sinus, basically dividing the cavity into smaller compartments. They act almost like internal tent poles.
That's a great way to picture it. And the Schneiderian membrane doesn't just drape casually over these septa. It is tightly, intimately adhered to them.
So you can't just push it up.
No. If a surgeon tries to lift the membrane without meticulously dissecting it away from the base, the sides, and the peak of the septum, the tissue will snag right on that bone spike and tear immediately.
Wow.
Additionally, a type B classification includes membranes that have been altered by chronic pathology. Like, if a patient has a history of chronic sinusitis, the membrane becomes thickened, fibrotic, and it loses its natural elasticity.
So it becomes stiff.
Stiff and brittle,
Yeah.
making it highly susceptible to tearing during elevation.
This preoperative classification, determining if the anatomy is stretch favorable or straight unfavorable, it dictates the entire surgical game plan.
It really does. It tells the surgeon which of the two primary surgical methods they must employ.
Let's start with the most traditional visually guided method, which is generally reserved for those difficult type B sinuses, or cases of severe atrophy where the remaining bone is less than 3 or 4 millimeters.
Right, this is the lateral window approach.
The lateral window approach.
It is heavily documented in the literature as the open or external sinus lift. The technique was pioneered by Hilt Tatum in the 1970s and formally published by Boyne and James in 1980.
Okay.
For decades, it has served as the absolute gold standard for massive bone reconstruction in the posterior maxilla.
I found the actual mechanics of this procedure intense.
It is a major surgery.
The surgeon makes an incision along the crest of the gum line where the teeth are missing, and then extends it vertically. They elevate a full-thickness flap.
Meaning they peel back the gum tissue and the underlying periosteum to completely expose the lateral surface of the jawbone.
Right. You were looking directly at the outer wall of the maxillary sinus,
You are, and then the surgeon has to breach that wall.
which sounds terrifying.
Using a handpiece, they outline a window in the solid bone. It is typically an oval or rectangular shape, roughly 10 to 15 millimeters in diameter.
They're cutting a literal access hatch into the side of the face.
A literal hatch, yes. Once the perimeter of the window is cut, the surgeon has an isolated plate of bone. But the interior surface of that bone plate is still intimately attached to the 0.1 millimeter Schneiderian membrane.
So they can't just rip it off.
No. The sources describe a few ways to handle this window. Sometimes they use a diamond burr to slowly grind the bone dust away until only the bluish hue of the membrane is visible.
Just grinding it down to nothing.
Yeah. But the more structurally fascinating method is the infracture technique.
I read about this. The infracture technique utilizes the bone window as a structural asset.
Exactly. Instead of removing the bone plate, the surgeon gently taps it inward, pivoting it on its superior border.
So the window swings upward into the sinus cavity, almost like a ceiling tile being pushed up into a drop ceiling.
That is the perfect visual. That isolated square of lateral bone actually becomes the new, rigid roof of the augmented sinus floor. As it swings up, it carries the attached Schneiderian membrane with it, initiating the elevation.
From there, the surgeon relies on specialized hand instruments called sinus curettes.
Right.
These have varying angles and curvatures designed to hug the contours of the sinus floor. The surgeon reaches through the lateral window, slides the smooth edge of the curette between the bone and the membrane, and painstakingly separates the tissue.
Working anteriorly, posteriorly, and medially toward the nasal wall.
It must require an incredible tactile sensitivity.
It does. The surgeon must keep the instrument in constant contact with the bone to avoid perforating the membrane. They have to carefully navigate over any septa or irregularities by feel.
Going back to the creation of that window, though, I was looking at the history of the instruments used for this. For a long time, surgeons were using traditional rotary instruments, high-speed spinning metal drill burrs.
Yes, traditional drills.
You are pressing a spinning blade into the skull to cut a window, while a microscopic wet tissue paper membrane is sitting right on the other side.
It's risky.
If the drill penetrates even a fraction of a millimeter past the inner cortex of the bone, the rotational friction instantly shreds the membrane. The complication rates must have been terrifyingly high.
They were, which is why the introduction of piezoelectric surgery in the early 2000s fundamentally altered the safety profile of the lateral window approach.
Piezoelectric surgery.
Yes, this is a brilliant application of physics to biology.
I spent a lot of time reading the studies on these piezoelectric devices. Instead of a spinning blade, the handpiece utilizes ultrasound.
Ultrasound, right?
The tip of the instrument vibrates microscopically at a very specific frequency, typically between 24 and 36 kilohertz.
And the genius of the piezoelectric device lies in the physics of cavitation.
Cavitation.
Yeah. The surgeon continuously irrigates the cutting site with a sterile saline spray. The ultrasonic vibration of the tip generates alternating high-pressure and low-pressure waves in that fluid.
Okay, I'm following.
During the low-pressure phase, microscopic vacuum bubbles form in the liquid, and then during the high-pressure phase, those bubbles violently implode.
And that implosion generates a highly localized shock wave.
Exactly. It releases a concentrated burst of energy. This micromechanical fracturing is highly effective at ablating hard, mineralized tissue.
So it cuts through the calcium matrix of the bone with extreme precision.
It does, but the critical advantage is the frequency tuning. The 24 to 36 kilohertz range is specifically calibrated to interact only with mineralized structures.
Oh, wow. So when the vibrating tip finally breaks through the inner layer of bone and touches the Schneiderian membrane, the tissue doesn't shred.
Right, because soft tissues, including mucous membranes, nerves, and blood vessels, possess natural elasticity.
So they just move with it.
They simply vibrate in resonance with the ultrasonic tip. They absorb the energy rather than resisting it. The tip literally bounces off the soft tissue without cutting it.
So it selectively cuts bone while totally sparing soft tissue.
Yes, this technological leap drastically reduced the membrane perforation rate during the window cutting phase, and the lateral approach gives the surgeon unparalleled direct visualization.
Because the hole is so big.
Right. They can look directly into the cavity, meticulously manage septa under direct sight, and pack enough biomaterial to achieve 8 to 10 millimeters of vertical height, which is sufficient for almost any implant.
But, and this is a big but, the clinical literature is very clear about the drawbacks.
Whoa, yes.
Peeling the face open and cutting a large window through the lateral wall is highly invasive.
Very invasive.
The disruption to the periosteal blood supply and the surgical trauma result in significant postoperative morbidity for the patient.
We were talking about extensive facial swelling, deep bruising, considerable pain, and a very protracted healing period.
The sources say in severe cases, the patient must wait 6 to 9 months after the sinus lift before the bone graft is consolidated enough to even attempt placing the dental implants.
6 to 9 months is a long time for a patient to wait, and the desire to mitigate that morbidity drove the development of the second major surgical technique.
Right.
If the lateral window is the open heart surgery of the jaw, the transcrustal approach is the minimally invasive endoscopic equivalent.
The transcrustal approach.
Yeah.
It's also referred to as the closed or internal approach.
Yes.
The literature indicates this is generally selected for patients who have slightly more native bone to work with, typically a residual bone height between 5 and 9 millimeters.
So they don't have enough bone for an implant, but they aren't completely hollowed out either.
Exactly. So instead of reflecting a large lateral flap and cutting a window, the surgeon approaches the sinus vertically, directly through the crest of the alveolar ridge.
They utilize the exact same 4-millimeter diameter hole that they are drilling to eventually house the dental implant itself.
Wait, really?
What?
All the elevation and grafting are performed through this narrow vertical corridor.
Everything.
I was reading about the origins of this. The original technique was published by Dr. Robert Summers in 1994.
The Summers technique.
And the mechanics he used seem almost medieval compared to modern tools.
Yeah, we're certainly aggressive.
The surgeon uses standard drills to create the implant hole, stopping roughly 1 millimeter short of the sinus floor.
Okay.
Then they insert an osteotome, which is basically a blunt calibrated steel rod, into the hole.
And then they use a surgical mallet.
A mallet.
A literal mallet. The surgeon taps the osteotome, forcefully fracturing that final millimeter of bone upward.
That sounds intense.
It is. The fractured bone plug acts as a buffer, pushing the Schneiderian membrane up ahead of it. The surgeon then packs small increments of bone graft into the hole, using the osteotome to condense the material and push the membrane higher.
So it's basically like building a ship in a bottle.
That is exactly what it is.
You are doing all this complex tissue elevation and space creation through a tiny 4-millimeter keyhole, and you are doing it completely blind. You cannot see the membrane.
You can't see a thing. And because you can't see the ship, the tools have to do the sensing for you.
Right.
The Summers technique relies heavily on tactile feedback. The subtle changes in resistance the surgeon feels through the mallet. But bone density varies wildly, you know?
So it's a guess.
If the surgeon misjudges the force, the bone plug can splinter, and the sharp edges will instantly puncture the unseen membrane.
Which you wouldn't even know happened.
Exactly. The blindness of the procedure absolutely necessitated safer, more predictable methods of elevation.
That brings us to hydraulic elevation.
Yes, fluid dynamics.
If you can't see the membrane, and rigid steel instruments carry a high risk of puncture, the literature shows surgeons turning to water.
Right. The surgeon prepares the osteotomy up to the sinus floor. Then they introduce a specialized syringe or a mechanized punk system that seals tightly against the walls at the drill hole.
Okay.
And they inject sterile saline into the osteotomy.
Because liquid is incompressible, the fluid builds up hydraulic pressure against the thin floor of the sinus.
Exactly. The pressure naturally seeks the path of least resistance. It gently fractures the remaining microlayer of bone and begins to pool underneath the Schneiderian membrane.
It just pushes it up.
The beauty of hydraulic pressure is that it applies uniform, perfectly distributed force across the entire surface area of the membrane.
Right, no sharp points.
It lifts the tissue smoothly and evenly off the bone without any sharp instruments or localized point pressure ever touching the mucosa.
It's like inflating a water balloon underneath a rug to lift it off the floor.
That's a great analogy.
Another variation of this I saw in the sources is antral membrane balloon elevation, or AMBE.
Yes, the balloon method.
This takes the balloon concept literally. The surgeon inserts a tiny deflated latex or silicone balloon catheter through the vertical drill hole, positioning it just under the membrane.
And then they inflate it.
Right, they use a syringe to slowly fill the balloon with a radiopaque fluid. As the balloon expands, it physically pushes the membrane upward. Once the desired volume is achieved, they deflate the balloon, remove it, and fill the newly created void with graft material.
It's very elegant. Both hydraulic and balloon methods drastically reduce mechanical trauma. But perhaps the most biomechanically fascinating advancement in the transcrestal approach is osseodensification.
I was absolutely captivated by the physics of osseodensification.
It completely flips everything we know about drilling.
Exactly. We typically think of drilling as a subtractive process. A normal drill bit, whether for carpentry or traditional orthopedic surgery, features spiral flutes designed to carve material away and pull the debris up and out of the hole.
You are removing mass to create a void.
Right. Osseodensification, popularized by the Densa burr system, fundamentally alters that paradigm.
How so?
The burrs have a unique, non-cutting geometric design. The surgeon uses these burrs in the implant motor, but they run them in reverse,
Counterclockwise.
counterclockwise, at high speeds, typically between 800 and 1200 RPM, accompanied by copious saline irrigation.
So they aren't cutting at all.
By spinning the uniquely shaped flutes backward, the drill no longer cuts and extracts bone. Instead, the reverse rotation generates a hydrodynamic compression wave.
A compression wave.
As the burr advances downward, it violently compresses and condenses the bone debris forward and laterally into the walls of the osteotomy.
Right, it utilizes the inherent viscoelastic plasticity of the jawbone.
Which means
It is taking the patient's native bone that would normally be drilled away and discarded and essentially autografting it right into the walls of the hole.
that is brilliant.
It drastically increases the bone density exactly where the implant threads need to grip.
And how does this reverse drilling translate to actually lifting the sinus membrane?
As the surgeon advances the reverse spinning burr to the very floor of the sinus, that condensed plug of native bone dust acts like a hydraulic piston.
Oh, I see.
The burr pushes this dense, smooth plug of bone upward against the Schneiderian membrane, safely elevating it.
So you are simultaneously lifting the sinus lining and hypercondensing the implant site, all through a single, minimally invasive protocol.
Exactly. And the clinical benefits for the patient are substantial. Because there is no large lateral flap, the blood supply to the periosteum remains completely intact.
Healing must be faster.
Remarkably fast. Patients experience minimal swelling and often report very little post-operative pain. Furthermore, because you are elevating the sinus through the exact implant preparation site, it is highly common to place the dental implant during the exact same surgical visit.
Oh, that's huge.
You combine the graft and the implant placement, eliminating the need for a second surgery months later.
The caveat, however, remains visibility.
Right. Always visibility.
Even with hydraulics, balloons, or osseodensification, the transcrestal approach is structurally blind.
Yes. If the membrane is exceptionally thin or if an undetected bone spur causes a microtear during elevation, the surgeon might not realize it.
And pumping bone graft blindly into a torn membrane leads to significant complications.
Severe complications. This is why stringent case selection, like limiting this approach to favorable type A anatomies with sufficient baseline bone, is a non-negotiable clinical standard.
So regardless of the method, whether the surgeon cuts a lateral access window or utilizes fluid dynamics through a vertical keyhole, we arrive at the exact same anatomical endpoint.
Right.
We have successfully elevated the membrane, creating an empty, confined space between the sinus lining and the alveolar bone.
We have the pocket.
Now we have to fill that void. The body needs a matrix to bridge the gap and generate dense, load-bearing bone capable of supporting titanium under the heavy mechanical forces of chewing.
And the selection of biomaterials to pack into that space is a critical component of this deep dive.
Let's get into it.
The literature categorizes these graft materials into 4 main groups, each with distinct biological mechanisms. The first is autogenous bone, or autografts.
This involves harvesting bone directly from the patient themselves.
Correct.
Usually the surgeon scrapes bone shavings from another area of the jaw, like the ramus or the chin. Or, in severe reconstructive cases, they actually harvest bone from the patient's iliac crest.
The hip.
The hip, yeah.
Biologically, autografts are the undisputed gold standard. They possess all three critical properties of bone regeneration.
Which are?
They are osteoconductive, meaning they provide a physical scaffold. They are osteoinductive, meaning they contain biochemical growth factors like bone morphogenetic proteins that actively signal surrounding cells to become bone-forming cells.
Okay, scaffold and signal.
And, crucially, they are osteogenic. They contain living, viable osteoblasts and stem cells that immediately begin synthesizing new bone upon transplantation.
So the biological integration is flawless because it's literally the patient's own tissue.
Flawless, but the logistical and patient experience drawbacks are severe. Harvesting autogenous bone requires a second surgical site. You are inflicting surgical trauma on another part of the patient's body simply to gather material. This significantly increases operation time, post-operative pain, and there's a risk of localized nerve damage at the donor site.
It's a lot to put a patient through. So to avoid the morbidity of a second surgical site, surgeons frequently turn to the second category, allografts.
Yes, allografts.
This is human bone harvested from a donor, obtained through a regulated tissue bank.
Because it comes from a different human, it has to be heavily processed to prevent immune rejection or disease transmission.
Obviously.
The tissue banks subject the bone to acid washing, irradiation, and freeze drying. By the time it reaches the oral surgeon, all the living cells and organic cellular components have been completely destroyed.
So what's left?
What remains is the mineralized calcium phosphate matrix and a small concentration of trapped growth factors.
Okay.
It serves as an excellent osteoconductive scaffold and retains some mild osteoinductive properties, but because it contains no living cells, it is not osteogenic.
Got it. The third category is apparently the most widely utilized material globally in sinus augmentation. Xenografts.
Xenografts.
This is bone harvested from an entirely different species.
Right.
In the context of dental surgery, the most heavily researched and utilized xenograft is deproteinized bovine bone mineral,
Cow bone.
cow bone. A prominent clinical example documented in the studies is BioOS. The manufacturing process for xenografts is extreme.
It has to be.
The bovine bone is subjected to intense chemical solvents and heat exceeding 300 degrees Celsius.
Wow.
This exhaustive processing ensures that absolutely zero proteins, peptides, or cellular material remain. It eliminates any potential for cross-species immune response or disease transmission.
But if the cow bone is essentially dead, calcified rock, how does the human body actually utilize it?
I was reading about the cellular mechanisms, and it's a fascinating process of osteoconduction.
Why choose bovine bone specifically?
It comes down to microscopic architecture. The trabecular porosity, basically the internal network of interconnected pores and tunnels of bovine bone, is remarkably similar to the cancel structure of human bone.
So it mimics our bone.
Perfectly. It provides the perfect physical scaffolding. When the surgeon packs this sterile, granular bovine mineral into the sinus cavity, the patient's blood immediately infiltrates those porous granules.
And the blood brings in platelets.
Right. The platelets release growth factors, signaling the patient's native mesenchymal stem cells and osteoblasts to migrate into the area.
So our cells do the work.
Exactly. These human cells physically attach to the surface of the cow bone granules. They use the bovine matrix as a climbing frame, slowly moving across the surface and depositing new, living human osteoid unmineralized bone directly onto the xenograft.
That is incredible.
Over months, osteoclasts arrive and begin slowly dissolving the bovine calcium, while osteoblasts replace it with human bone in a process called creeping substitution.
Creeping substitution.
Xenografts are exceptionally slow to resorb, which makes them unparalleled for holding space and maintaining long-term volume in the sinus.
Now, the fourth category provides an alternative for patients who refuse human or animal products. Alloplasts.
Alloplasts,
These are entirely synthetic materials manufactured in a laboratory.
like ceramics.
Yes, these are ceramics like hydroxyapatite, beta-tricalcium phosphate, or bioactive glasses. They're purely osteoconductive scaffolds.
So just the climbing frame.
Right. They carry zero risk of disease transmission, and their resorption rates can be precisely engineered by altering the ratio of hydroxyapatite to calcium phosphate.
Okay, so while packing these various materials into the sinus is the standard protocol, the clinical literature presents a highly counterintuitive technique that kind of challenges our assumptions about bone regeneration.
Yes, the graftless alternative.
I was completely arrested by this section of the research.
It's wild, right?
In specific clinical scenarios, typically when the patient has 4 to 5 millimeters of residual bone, which is just enough to achieve initial mechanical stability for the implant surgeons, will elevate the membrane using the transcrestal approach, thread the titanium implant into place so it protrudes up into the tented space, and then they don't add anything.
Nothing at all.
No autograft, no cow bone, no synthetics.
Yeah.
They leave the space entirely empty.
They leave it filled with nothing but a naturally occurring blood clot.
It sounds impossible.
It does.
Without a dense scaffold of calcium to support it, why doesn't the heavy Schneiderian membrane simply collapse back down onto the apex of the implant, flattening the space? How does a liquid blood clot transform into load-bearing jawbone out of thin air?
Your mechanism relies entirely on the inherent osteogenic potential of the Schneiderian membrane itself, combined with the physical presence of the implant. The membrane is not a passive sheet of tissue. The periosteel layer, the side of the membrane that was originally attached to the bone, is highly vascular and densely populated with pluripotent mesenchymal stem cells and osteoprogenitor cells.
When the surgeon forcefully peels the membrane off the bone floor, that mechanical separation induces localized microtrauma, right?
Exactly. This trauma is a vital biological trigger. It initiates an acute inflammatory cascade. Blood rapidly pools into the newly created void beneath the elevated membrane and coagulates into a stable hematoma, a blood clot.
A blood clot.
Yes, and this clot acts as a highly active temporary biological scaffold. It is absolutely saturated with platelet-derived growth factors and vascular endothelial growth factors.
And what do those do?
These biochemical signals stimulate rapid angiogenesis. That's the sprouting of new blood vessels from the surrounding bone walls and the membrane itself right into the clot.
As for the structural support, the titanium implant itself acts as the central tentpole.
It does.
It physically props the membrane up, maintaining the volume of the cavity. Stimulated by the growth factors in the clot and the mechanical tension of being held in an elevated position, the stem cells within the Schneiderian membrane differentiate into active osteoblasts.
The builders.
The builders. The membrane itself begins depositing woven bone downward into the clot, while the native floor of the jawbone begins growing bone upward along the threads of the implant.
The bone formation basically converges from the periphery toward the center, eventually ossifying the entire blood clot into solid, functional bone.
Wow.
The graftless technique is a profound demonstration of the body's regenerative capacity. It proves that given the right mechanical space and a stable blood supply, the body can literally synthesize its own foundation.
However, the sources emphasize a critical caveat. The graftless technique, and indeed any sinus lift, demands a perfectly isolated environment. The blood clot, or the particulate graft material, must be entirely contained, which forces us to address the most prominent complication detailed in the literature. What happens when the 0.1 millimeter Schneiderian membrane tears?
Membrane perforation. It is the undisputed leading complication of sinus augmentation.
How common is it?
The systematic reviews highlight a significant incidence rate. Across all sinus lift procedures, perforations occur in roughly 30.6% of cases.
30%.
And in studies that isolate the more technically demanding lateral window approach, especially in cases with complex type B anatomy, the perforation rate can soar to over 60%.
That means in complicated cases, more than half of the patients will experience a torn membrane during surgery. For a routine dental procedure, that is a staggering failure rate of the tissue.
It is a high frequency of occurrence, but the clinical reality is that a perforation is generally viewed as a manageable intraoperative event, provided the surgeon has the visibility to recognize it and the skill to repair it immediately. The management protocols are strictly categorized by the physical dimensions of the tear.
I was reviewing the surgical triage for this. Let's look at the protocols for different tear sizes. If the perforation is small class, is less than 5 millimeters in length.
A micro tear of less than 5 millimeters is relatively straightforward to manage. In some instances, the natural coagulation of the blood clot is actually sufficient to seal a pinpoint puncture.
Okay.
However, the standard of care usually involves the surgeon applying a layer of fibrin glue, or more commonly, placing a resorbable collagen membrane right over the defect.
The surgeon essentially slides a biological patch between the bone graft and the torn tissue.
Exactly.
The wet collagen adheres to the membrane, bridging the gap and acting as a physical barrier to prevent the granular bone graft from spilling through the hole. The body eventually resorbs the collagen patch as the membrane heals itself.
But the complexity escalates significantly with a medium perforation, typically defined as 5 to 10 millimeters in length.
That's a bigger tear.
A simple collagen patch is insufficient. because the physical tension of the graft pushing against it will cause it to cave in or dislodge.
I was reading the management protocols for a 6 millimeter tear, and the dexterity required is just hard to comprehend.
It's microscopic work.
The solution isn't just a patch. The surgeon actually has to break out microscopic surgical thread, often a resorbable polyglycolic acid suture like C-Fil 4.0, and literally stitch the edges of this wet 0.1 milliliter tissue back together inside the dark, confined hole of the jawbone.
It's mind-boggling. The suturing is exceedingly delicate because any excess tension on the thread will simply cheese wire through the fragile tissue and widen the tear.
Cheese wire through it. Yikes.
Once the surgeon manages to approximate the edges with sutures, they must reinforce the repair. They will layer a collagen membrane over the stitches, and frequently they will introduce a piece of cortical laminar bone.
What's that?
This is a thin, rigid sheet of sterile allograin bone. They wedge it against the internal walls of the sinus, right over the tear, to provide a solid mechanical shield against the pressure of the particulate graft.
Okay, so that's for a medium tear. But what if the tear exceeds 10 millimeters? A macro perforation.
A tear larger than 10 millimeters represents a major structural breach. The entire barrier function of the membrane is lost. A collagen patch will collapse immediately.
So what do they do?
In these extreme scenarios, the surgeon has to recruit heavy biological reinforcement. They may have to execute a complex dissection to mobilize the buccal fat pad.
The buccal fat pad.
Yes, it's a distinct mass of encapsulated fat located in the cheek. They drag a vascularized pedicle of this fat into the sinus window to physically plug the massive defect, relying on the rich blood supply of the fat to facilitate rapid healing.
Wow.
Alternatively, they may have to harvest a solid, customized block of autogenous bone from the patient's mandible and physically wedge it into the sinus to wall off the tear before they can safely introduce any particulate grafts.
And if they can't do that?
In the most severe cases, the surgeon must completely abort the procedure, allow the membrane to heal for several months, and just attempt the surgery again later.
The surgical stress of managing these tears must be immense. But I found a statistical anomaly in the meta-analysis of 3,604 implants that completely reframed this whole thing for me.
Oh, yeah.
The study tracked the long-term survival rates of the titanium implants placed into these grafted sinuses.
The outcome data.
Right. When the Schneiderian membrane was elevated flawlessly, remaining completely intact, the implant survival rate was a highly predictable 98.88%.
An exceptionally high success rate, indicative of a reliable procedure.
But if the membrane was torn during surgery, and the surgeon executed one of those complex repairs, the microstitching or the collagen patching, the implant survival rate was 97.68%.
The statistical variance is just over 1%.
Exactly my point. If a torn, stitched-up membrane only diminishes the chance of implant survival by 1%, why do oral surgeons treat a perforation as an absolute crisis? Why go through the agony of suturing wet tissue paper if the titanium implant is almost guaranteed to integrate regardless?
It is a critical distinction between the success of the hardware and the health of the host. We aren't sweating the repair to save the implant. We are meticulously sealing that membrane to save the maxillary sinus ecosystem.
We have to keep the graft out of the breathing cavity.
Precisely. If a perforation is left unmanaged, or if a patch fails under pressure, the granular bone graft material, specifically the dense, non-resorbing granules of bovine xenograft, will migrate through the defect and spill out into the open sinus cavity.
So you have loose, particulate cow bone rattling around inside a mucosal environment.
And earlier, we discussed the microscopic cilia lining that membrane. Their entire biological imperative is to continuously sweep foreign debris upward toward the sinus drain, the ostium.
The cilia will naturally identify the bone granules as foreign bodies and attempt to clear them.
Right. But bone graft granules, especially those larger than 1 or 2 millimeters, are way too massive for the mucociliary clearance system to process effectively. The granules get pushed upward and physically lodge into the narrow anatomical bottleneck of the ostium.
They block the drain.
They block the drain.
A blocked drain in a warm, dark, mucus-filled cavity is the perfect recipe for severe pathology.
It induces acute or chronic maxillary sinusitis. The mucus backs up, the sinus cavity fills with fluid, and opportunistic bacteria rapidly proliferate.
What does the patient feel?
The patient will present with severe localized facial pain, significant swelling, nasal congestion, and the discharge of purulent exudate pus into the nasal cavity.
Oh, it's terrible.
The localized infection can compromise the entire graft site, leading to massive bone loss and ultimate failure of the surgery.
The sources also detail a bizarre cascading neurological complication resulting from graft migration. Benign paroxysmal positional vertigo, or BPPV.
Vertigo is a profound complication. The anatomical proximity is key here. The maxillary sinus is situated intimately close to the complex structures of the inner ear, specifically the vestibular system which controls human balance.
But how does a loose bone chip in the cheek cause vertigo?
Severe chronic inflammation in the maxillary sinus, combined with the mechanical disruption of heavy bone particles migrating through the mucosal spaces, can trigger secondary inflammatory responses or structural disturbances in the adjacent vestibular apparatus.
So it leaks over to the ear.
Basically, yes. Patients experience intense, debilitating episodes of dizziness and spatial disorientation triggered simply by changing the position of their head. It transforms a dental procedure into a profound neurological quality of life issue.
We repair the membrane not to save the 1% of implants, but to protect the patient from chronic facial infections and vertigo.
The integrity of the sinus cavity is absolutely paramount.
Which brings us to the crucial necessity of pre-surgical planning and the multidisciplinary approach. Because a sinus lift operates directly on the boundary between the oral cavity and the respiratory tract, it frequently bridges the gap into ear, nose, and throat ENT medicine.
That anatomical border zone is why a standard 2D panoramic dental X-ray is considered almost gross malpractice for sinus augmentation planning.
You need more detail.
The absolute standard of care is a CBCT scan cone beam computed tomography.
The surgeon needs a high-resolution 3D volumetric map of the skull.
They must interact with the anatomy in 3 dimensions. The CBCT allows the surgeon to definitively map the presence and angulation of underwood septa, accurately measure the existing residual bone height to the millimeter, and evaluate the baseline thickness of the Schneiderian membrane to predict its elasticity.
Go.
Critically, the scan is used to trace the path of the alveolar antral artery.
An intraosseous artery.
Yes. In a significant percentage of patients, this artery runs horizontally straight through the lateral bony wall of a maxillary sinus.
The wall they need to cut a window in.
Exactly. If a surgeon performing a lateral window approach fails to identify its location on the 3D scan and inadvertently severs it with a piezoelectric drill or a curette, it triggers massive pulsatile bleeding that completely obscures the surgical field and can be incredibly difficult to ligate, jeopardizing the entire procedure.
But the 3D imaging serves another vital purpose. It forces the oral surgeon to actively screen for existing ENT diseases.
It really does.
The sources presented a fascinating clinical case study that perfectly illustrates how critical this crossover is. Let's walk through the timeline of the 65-year-old female patient.
This case is a textbook example of multidisciplinary care. The patient presented to the oral surgeon requesting a dental implant at anatomical site 15, which corresponds to the upper right second premolar.
Okay.
Clinical examination revealed severe vertical bone atrophy, clearly indicating the necessity for a sinus lift.
But when the oral surgeon analyzed her CBCT scan, they identified a severe pre-existing pathology. The sinus wasn't just hollow, the membrane was grossly abnormal. The diagnosis was sinonasal polyposis.
Sinonasal polyposis is a manifestation of chronic diffuse rhinosinusitis. The mucosal lining of the patient's sinus was locked in a state of severe chronic inflammation.
And this prolonged inflammation caused the tissue to hypertrophy and form bilateral edematous polyps.
Let's define polyps in this context. They are essentially teardrop-shaped, non-cancerous, fluid-filled growths protruding from the mucous membrane.
And in her case, these fleshy masses had proliferated to the point where they were physically obstructing the middle meatus, the critical drainage pathway of the sinus cavity.
Her sinus drain was completely blocked before the dental surgeon even touched her.
Wow.
If the oral surgeon had ignored the radiograph, proceeded with the lateral window, elevated the diseased membrane, and packed a massive volume of particulate bovine bone into that cavity, the outcome would have been disastrous.
How so?
The inevitable post-surgical swelling, combined with the introduction of foreign graft material into a sinus cavity that physically lacked the ability to drain, would have generated a severe localized infection. The graft would have become necrotic, the implant would have failed, and the localized infection could easily have breached the orbital floor or spread systemically.
The oral surgeon recognized the impending failure and immediately halted the dental treatment plan. They referred the patient directly to an ENT specialist.
The ENT assumed control of the case. The patient underwent an extended regimen of medical management and eventually functional endoscopic sinus surgery, or FASS, to physically excise the polyps and surgically widen the blocked drainage pathways.
The case study notes that following the ENT intervention, the patient recovered 80% of her olfactory function, her sense of smell, which had been suppressed by the disease.
That's a great outcome.
Post-operative endoscopies definitively confirmed that her sinus ostium was fully patent. The drainage system was open and functioning normally.
Only after the ENT officially cleared the patient, confirming the sinus was structurally healthy and capable of managing post-operative inflammation, did the oral surgeon resume the case.
But even with the polyps removed, the oral surgeon treated her as a high-risk scenario. When they finally executed the lateral window sinus lift, they utilized an aggressive pharmacological protocol.
Right.
They prescribed heavy antibiotic prophylaxis 2 grams of amoxicillin prior to the incision to mitigate infection risk. And crucially, they utilized systemic corticosteroids.
The steroid administration, specifically 1 milligram per kilogram of body weight, was a highly targeted intervention.
Because of the inflammation.
Yes. The surgical trauma of the sinus lift inherently causes localized inflammation. In a patient with a history of hyperinflammatory polyposis, that surgical trauma could easily trigger the membrane to aggressively swell and initiate a recurrence of the polyps.
So the systemic steroids forcibly suppress the immune response.
Keeping the mucosal inflammation to an absolute minimum while the bone graft stabilized.
Thanks to the 3D imaging, the ENT collaboration, and the strict pharmacological control, the sinus lift was a complete success. The bone graft integrated perfectly without any sinus complications.
A great success story.
It's a vivid reminder that an oral surgeon isn't just treating a localized hole in the jaw. They are operating on a highly integrated biological system.
They absolutely are.
But while we are analyzing risks, the literature universally highlights one massive behavioral risk factor that is entirely within the patient's control, and it is catastrophic for bone regeneration.
The clinical data on smoking is completely unambiguous.
Why is smoking so profoundly destructive to a sinus lift?
Bone regeneration is fundamentally dependent on robust angiogenesis. That's the creation of a dense network of new blood vessels to supply oxygen and nutrients to the stem cells and osteoblasts.
Right, the blood supply.
The nicotine and carbon monoxide introduced through cigarette smoke induce severe systemic vasoconstriction. The peripheral blood vessels artificially clamp down and shrink.
So you are basically choking off the blood supply to the surgical site.
Exactly. The compromised microcirculation means a fraction of the necessary oxygen, growth factors, and immune cells reach the newly packed bone graft. Furthermore, the localized heat and toxic chemical load in the oral cavity directly impair the function of fibroblasts, the cells responsible for soft tissue healing.
The studies indicate this leads to a massive increase in membrane perforations because the ischemic tissue is weak and friable.
Yes.
It drastically elevates the risk of post-operative infection because the immune response is crippled. But the most visible failure is an increase in wound dehiscence.
Dehiscence is a catastrophic failure of the soft tissue closure.
Meaning the stitches come undone.
Worse. The edges of the gum incision basically fail to fuse together and heal. The incision literally pulls apart, exposing the underlying sterile bone graft to the highly contaminated, bacteria-rich environment of the oral cavity.
Oh no.
Once the particulate graft is exposed to saliva, it rapidly becomes infected, the granules wash away, and the entire reconstructive effort fails.
The biological disruption is so profound that many oral surgeons implement strict, non-negotiable cessation protocols, requiring patients to completely abstain from smoking for several weeks before and months after the surgery, or they simply refuse to perform the procedure entirely.
The surgical precision and advanced biomaterials just cannot overcome the physiological limitations imposed by severe vasoconstriction.
To synthesize this incredible biomechanical journey, we basically start with the localized loss of a single tooth.
Just one tooth.
That single event triggers a dual collapse. Deprived of the mechanical stress of chewing, the osteoblasts shut down and the osteoclasts dismantle the alveolar ridge.
The floor drops.
Simultaneously, the pneumatic pressure of respiration pushes the weakened sinus floor downward, hollowing out the skull.
The ceiling caves in.
We establish the clinical threshold. When the residual bone height drops below 5 to 7 millimeters, the architecture must be rebuilt before an implant can be safely anchored.
We analyzed the delicate environment of the 0.1 millimeter Schneiderian membrane, relying on its 132% stretch limit to create a confined space.
We explored the structural ingenuity required to manipulate that space. The traditional lateral window approach, utilizing the 30 kilohertz cavitation physics of piezoelectric ultrasound to safely ablate bone without shredding the adjacent soft tissue.
And the minimally invasive transcrustal approach, avoiding large incisions by utilizing the uniform pressure of hydraulic fluid dynamics.
Or the counterclockwise hydrodynamic compression wave of an osseodensification burr to push the floor up through a 4 millimeter keyhole.
We unpacked the cellular mechanisms of the biomaterials, how the trabecular porosity of sterile bovine xenograft provides a climbing frame for human osteoblasts.
And the paradoxical magic of the graftless technique, where the microtrauma of elevation triggers the membrane's own stem cells to ossify a contained blood clot.
We confronted the reality of the 30% complication rate, detailing the microscopic suturing required to repair the tissue, not to save the implant, but to prevent graft migration from causing chronic sinusitis or vertigo.
And finally, the necessity of 3D volumetric planning and ENT collaboration to ensure the physiological drainage of the sinus is patent before introducing surgical trauma.
It is a really profound demonstration of how modern medicine can manipulate human physiology.
It truly is. But as we wrap up this deep dive into the source material, I want to leave you, the listener, with a broader thought to mull over. Today we learned that the simple, repetitive act of chewing on a tooth provides an invisible piezoelectric mechanical stress that literally dictates the physical density of your skull, preventing your air sinuses from expanding and hollowing out your face.
It's an amazing system.
It is a stark example of Wolff's Law in action. It makes you wonder what other microscopic architectures in your anatomy are completely dependent on constant invisible mechanical forces just to maintain their structural integrity. What other vital physiological functions are we subtly losing because we aren't actively using them?
It is the fundamental law of our biology. The body is a ruthless architect that demands constant mechanical proof that its structures remain necessary.
Keep proving it. Thank you for joining us on this deep dive into the source material. Keep exploring the incredible engineering of your own biology, and make sure to check the foundation before you try to build the kitchen island. See you next time.